مساء الخير. مش هطول طبعا، انا عارف اليوم كان طويل، بس انا الاول بشكر طبعا دكتور احمد عبد الهادي وليدرز طبعا جروب لدعوتي ابقى موجود النهارده معاكم. وفي نفس الوقت بشكر طبعا جانسن لدعوتي فور ذس توك. طبعا هنتكلم ماي بوينت او المين ايم بتاع التوك بتاعتي is doublet versus triplet. How transforming the metastatic hormone-sensitive prostate cancer treatment paradigm. These are my disclosures. This was a man, he was 57 years old, served as an engineer, although former smoker, but he quitted more than 30 years. فكان مبطل بقاله فترة. He's active, he's going برضو exercising at least 3 times per week. Since he was 50, he started to have some problems with in the urology. In the urine problem. His PSA was more, we can say it was normal, and then it started, PSA started to rise up to 98 at the end. But how he feels, he was better, he was okay, but he had some lumbar pains. lumbar pains شوية وجع في ظهره، فابتدى for the last year قعد 3 شهور ما ربطش طبعا ان في حاجة، بس eventually ال PSA كان واطي وعالي. عملنا السي تي، عملنا bone scan, they were performed showing the metastatic disease in the bone affecting multiple sites. So this is the treatment landscape of the advanced prostate cancer. We can say that it's a local androgen deprivation therapies after ADT, and then we have the hormone sensitive or the castration resistant. If you're talking about the hormone sensitive, then we have more than one option, as we can see here, and as Dr. Muhammad just said. And the non-metastatic or the castration resistant, we have more than one drug, plus there are new drugs coming up. We're talking about olaparib, it could be used, rucaparib, and as well as the lutetium. So in the disease classification, we have 2 stratifications. They are partly overlapping, more or less. So in the volume, this was in the charted trial, high volume, we're talking about more than 4 bone metastases, at least 1 extra axial or visceral metastasis. The low, not high volume, definitely. And in the risk was in the latitude, we had 2 out of 3 risk factors, either Gleason score above 8, 3 bone metastases, and measurable visceral metastasis. Definitely others will be low. So the high volume de novo metastatic disease is associated with the poorest prognosis. As we can see here, definitely the high volume is the worst. And the NCCN guidelines, they showed this. This was the recent NCCN guidelines. It was the version for 2026. And as you can see here, there was a difference between synchronous and metachronous. Synchronous metastasis means that it is at the beginning it was there were metastases. Metachronous, it came on later on in his disease. What about the European guidelines in 2025? They were strong thing for discussing with the patients the hormone sensitive metastatic disease, because most of our patients, we know that they are old, they need to understand what that's happening to them, and it's very important, and they get used to it actually. Also, they do not offer AR antagonist monotherapy in patients with MOI disease. This hasn't, they said it's a strong rate, as well as they had some supportive care importance with the patients, because to make them understand the history, because actually the patient of the prostate cancer, he's going to live with you are the doctor or the physician is going to live with him for a very long time. So what are the key clinical trials, the chemohormonal phase 3 trials in metastatic hormone sensitive? We have the charted, the Stampede, and the 𝐃𝐸 15. The charted, they had the docetaxel versus the ADT, and the Stampede was the docetaxel plus prednisone versus ADT. The 𝐃𝐸 was docetaxel versus ADT, and most of them, either in the medium follow-up, was definitely was high, wasn't bad. The charted was 53, but we go with the Stampede and the 𝐃𝐸 also it became higher, 78 to 83, as well as the overall survival. This was the charted, the high volume versus the low volume. Is it the same in the both arms, in the high volume and the low volume? Definitely, the median follow-up was of 53.7 months in patients with metastatic hormone-sensitive prostate cancer, randomized to ADT plus docetaxel versus the ADT. But in the low volume, it was not at all, as we can see here. And if we in metastatic hormone-sensitive prostate cancer, apalutamide plus ADT was studied in the Titan trial, as we can know. And then we had in the 𝐓𝐫𝐢𝐻 trial, we had the darolutamide plus docetaxel plus ADT, as well as the PEACE-1 trial, as we can see here. Formally, the question about what is the added value of adding docetaxel to ADT plus androgen receptor signaling inhibitor has not been evaluated. So what about the efficacy? If we're talking about the efficacy, the apalutamide in the Titan trial, the apalutamide plus the ADT, as we all know, the overall survival rate was 48 months. 65.1% versus 51.8%. Half of the patients in the apalutamide ADT arm achieved undetectable PSA level. And estimated the median overall survival of 71 months for the patient who received apalutamide plus ADT, compared to 47 months for the placebo arm plus the ADT, as we can see here, as well as the deeper and earlier recognized PSA decline. When was this happen? Undetectable PSA, as we know. We said that the undetectable PSA was less than 0.2 nanogram per ml, and this is the number which we go with. As you can see here, it was associated with improved outcome if it's deeper and earlier, as we will see later on. And we can see here, sorry, that in the apalutamide in the Titan trial, it happened after 3 months, and we can see later on we'll show that in other trials it was longer than this. We had 8 months and we had 6 months as well. What about the ARASENS trial, which used the darolutamide plus docetaxel plus ADT? The overall survival rate at 48 months was almost 62 versus 50.4%. Half of the patients achieved undetectable PSA level after more than 6 months. So this is the difference. I mean, we had the undetectable prostate PSA after 3 months. This is after 6 months. So it takes a longer time. And a sensitivity analysis was done in the ARASENS study for subsequent therapy, as death event showed median overall survival of 49 months compared to 31 months. If you go into the PEACE-1 study, which we used the abiraterone docetaxel ADT, median overall survival was almost 68 months versus 56. Half of the patients in this arm, in the abiraterone, had an undetectable PSA level after 8 months. So it took them a longer time to achieve a response. So in summary, these are the 3 trials which in the metastatic hormone-sensitive prostate cancer, but there's no head-to-head data available. We cannot take any conclusions more or less from this because it hasn't been done head-to-head. As you can see here, the median overall survival is in the 3 trials, as well as the undetectable PSA. But does the disease volume, المهم جدا الvolume والtype at presentation matter? Will it differ from the beginning, or it will not? So in the ARASENS study, no significant overall survival benefit was demonstrated for patients with low volume. So as you can see here in the curve on the right side, the low volume, there was no difference between patients with in the low volume disease. No survival benefit, definitely. There was no significant overall survival benefit in the patient with low volume. I'm sorry. In the Titan trial, for the patients with metastatic hormone-sensitive, the apalutamide plus ADT versus the ADT significantly delaying radiographic progression or death, prolonging overall survival. But not only it has done this in the high volume as well as in the low volume. So in the Titan, as we said, adding the apalutamide to ADT significantly improved overall survival irrespective of disease volume, so either the high volume or the low volume, and the timing of metastatic presentations. As you can see here, the apalutamide improved overall survival in the patients with worse prognosis, either synchronous, worse prognosis, as we know, the synchronous metastasis, or the heavy volume and high number of bone metastases, more than 10, as you can see here. Okay. And then the key message is what I want to say: apalutamide definitely improved the overall survival and the radiographic progression-free survival in patients with metastatic hormone-sensitive prostate cancer and high disease burden. So definitely it had a lot to play in this part. In summary, these are in the Titan. We can use triplets do not improve overall survival in low volume, and this is the message which I want to give you, that the triplets do not improve overall survival in the low volume. What is the added value of adding docetaxel? Because we used to say, no, the docetaxel is going to be the drug of choice, we have to give the docetaxel. So what is the added value of adding docetaxel to ADT plus the RSI? Formally, the question about what is the added value of adding docetaxel ADT plus an ERSA has not been evaluated. As you can see here, we have a lot of studies which has been done, and there is no statistical significance or overall or benefit. The benefit was only slightly in the heavy volume disease. And this, the indirect comparison of triplet therapy and novel hormonal therapy doublets in patients with metastatic castration sensitive. As we can see here, definitely adding doublet definitely has a better survival, a good survival for our patients, as you can see here, as well as in the radiographic in the NMA from Nabil et al. Presented at ASCO 2022, demonstrated that the addition of docetaxel triplet may not delay progression or prolonged survival compared with NHT-based doublets. So this gives us also a clue that the doublets definitely is better than using the triplets. So triplet therapy may not delay progression or prolong survival compared to doublets. In ASCO 2025, triple switch randomized. This is a trial which is still ongoing, phase 3 triple switch. Randomized phase 3 for the addition of docetaxel to androgen receptor pathway inhibitors in patients with metastatic hormone sensitive and with suboptimal PSA response. And we are waiting for the result, definitely. What about the safety? In essence, many of the most common adverse events reported are known toxic effects related more to docetaxel. As we know, the docetaxel is really a drug which has a very large or side effects, and sometimes you cannot continue the treatment if you're using docetaxel. In our essence, treatment with docetaxel in the first 4 months was associated with a great rate of all-cause hospitalization. So most of the patients had to go in the hospital a couple of times, maybe neutropenia, weakness, mainly these are with some fever as well. In PEACE 1, grade 3 or worse adverse events reported in more than 5% of the patients. Were included included was the hypertension, neutropenia, hepatotoxicity, but in more than 5%. And as you can see here, in the Titan trial, the apalutamide plus the ADT demonstrated a manageable safety profile. Then it's not going. We're not going to hospitalize the patient. Will be given the treatment for the side effects, and it will go through without any problems for the patient. Toxicity, at least initially, is superior for triplets versus doublets, and as we know, the triplets definitely the toxicity will be higher in using the triplets than the doublets. So in conclusion, the risk of grade grade more than 3 adverse events, serious adverse events. Any adverse event were consistently lower with the doublet regimen versus docetaxel based. Apalutamide plus ADT demonstrated a favorable safety profile compared with other doublet and triplet regimen. And the results of this safety, the NMA contribute important information for treatment strategy in the planning itself for the metastatic hormone-sensitive prostate cancer. It is not clear that added toxicity because of docetaxel is counterbalanced by added benefit. It's not clear in the different type of trials which we just seeing now. The risk of increased toxicity of triplets versus doublets is the lower toxicity, better quality of life, higher clinical benefit for the doublets. The quality of life is important because you're treating a patient who's having the disease. You're not treating a disease only, so you have to be to worry about the quality of life for the patient, because he's going to receive the treatment for a long time. So since patients with metastatic hormone sensitive are living much longer, it is vital that the quality of life to be maintained. As you can see here, it's very important for them. They can accept the treatment and they can live normal life after that. Apalutamide plus ADT versus ADT maintains the quality of life and stable energy levels versus baseline. I think in different trials, in the different trials we saw this, and as long as also in our practice we see that giving the treatment really doesn't cause any affecting the quality of life of our patients. In the Essence trial, time to worsening of disease-related physical symptoms was maintained with the addition of darolutamide in the overall population. And the treatment with docetaxel first 4 months was associated with a greater rate of all-cause hospitalization, as we just said. So the patient time is important. Patient's time is very valuable. The time toxicity of cancer treatment is important. The number of visits, hospital infusions, analysis, emergent visits, hospital admission. So it's very important for us, for the patient time. It's valuable. It's not a trip or something. Yeah. The patient preference should be considered a non-curable disease. Definitely, we know that it's a non-curable disease. It's a chronic disease. He's going to be with disease for a long time. So the preference also is important, that he accepting the type of treatment we are giving. So we are going consider doublets if it's a low volume metachronous, poor performance status, poor bone marrow reserve, neuropathy, presence of SPOP alterations, genetic alterations as well. And if we go to we can consider the triplet if fit for chemotherapy, if high Gleason score with lower PSA, significant tumor mass, bulky disease, and if they are triple negative TP53, P10, and retinoblastoma loss as well. So my key takeaway messages: apalutamide plus ADT significantly improved overall survival versus ADT, irrespective of disease volume, whereas the triplets didn't show any significant overall survival benefit versus comparator for patients with low volume disease. In the Titan, half of the patients achieved undetected PSA level by 3 months, as we just said. The time for half of the patients to achieve undetected PSA in Essence and PEACE-1 was more than 6 months and 8, respectively. Treatment discontinuation due to toxicity, we have 11.8 in the apalutamide, in Titan 13.5 in the darolutamide, and in the Essence almost 17 to 21%. NMA showed that apalutamide and ADT had the lowest relative risk of alternative treatment risk among all alternative treatments in the metastatic hormone sensitive for grade more than 3 serious side effects or adverse events. Apalutamide that ADT maintained the quality of life compared to ADT alone. Evaluating quality of life is very important using the FACT-P scale scoring has compared with baseline. In metastatic hormone sensitive, the treatment choice will most likely be driven by fitness, the nature of the disease, is it low or high volume, synchronous or metachronous, patient preference, and the specific side effects and availability. Apalutamide is the extra hormone treatment, allowing you to save more line of treatment for later stages. Thank you very much.
Thank you.